childhood onset mole that sometimes occurs in adults is a blue nevus, and they're not so common, and you usually only have one of those, but some people have more than one. And they are called a blue nevus by a pathologist, but actually they're usually blue. Funny that. They're not always blue. They can be yellowish or greenish or brownish or greyish, but mostly they're sort of steelish blue. They have a very characteristic histology where the nevus cells, instead of being rounded up, are elongated, spindle-shaped. And they're dendritic, so they've got arms and legs. And they produce an awful lot of pigment. And an awful lot of pigment deep down in the skin looks blue. And that's important to remember, because melanoma sometimes has blue in it, and if you see blue in a melanoma, you know it's deep. Which of these is blue nevus? Okay, very good. Most people have got the same answer that I think. And Chan, where's Chan?
Yeah.
Chan, which did you choose and why?
I chose B as the nevus, and then because I thought A, like melanoma, was slightly asymmetric. Well, that was my reasoning.
Okay, and this is a nice steel blue colour.
Yeah.
Do you still think it's melanoma?
No.
We read it here. So, hemangiomas are made of blood, which is red, but just the same effect of the colour change that blue, obviously venous blood is blue, but the colour of blood in an angioma depends also on its depth. So angiomas can be blue, they can be red, they can be purple, but often with the naked eye they look black. And it's not till you get dermoscopy that you either see red, blue, or in this case purple. And the blue nevus has got some yellowish brown in it. It's not just blue. And it looked just like a circle there, but when you look on dermoscopy, you see it has some radial lines, so lines coming out from the center. Now, that's only a small proportion of blue nevi have those lines, but they sometimes do. And the typical pattern for an angioma is clods, purple clods. And we wouldn't call this a globular nevus because those are brown clods, they're purple ones. And this name, lacuna, is going to go, so I'm going to get rid of that. The Dermoscopy Society agreed that some terminology was stupid, and we all agreed that this one was stupid. So because who knows what lacoon means? Lake, but most of us don't talk about let's go and look at the lacoons. It's not kind of normal terminology, so that's gone. Now you can have a blue nevus inside another nevus, because after all a blue nevus is just a deep dermal nevus, so you could have a congenital or tardive nevus that had blue nevus in the middle at the bottom, but it had a sort of normal nevus of the rest of it. In which case you're going to have brown. This one's not a very pigmented one, so it's a bit pinkish. So is this one a bit pinkish, but finding brown moles with these in are not typical. So combined nevi are not terribly common. They often get excised because people think, oh, what's that blue spot doing? It maybe it's a melanoma. But that's not how melanoma behaves. It doesn't start with a blue spot in the middle. It doesn't make any sense. That's not, as you'll see. So, but as they're not common, it's better if you're not sure. It's perfectly fine to excise it. You certainly don't want to leave a deep blue focus of melanoma growing away because it would be deep. So the histology shows small round cells producing the brown part of the mole and deeper spindle-shaped cells forming the blue bit. And I don't have very many pictures, but mostly the blue component is in the middle. Just didn't. So another type of dermal nevi, so remember childhood nevi of dermal, is this kind that's very soft and wobbly and papillomatous nevis, and they tend to be on the trunk or the proximal limbs. Not everybody has them, but they're quite common. And they start off flat. So you don't see these in young children because they have to pop out somewhere. They don't suddenly appear. So they start as a flat nevus, and later on they become a papillomatous nevus. And people don't seem to notice it happening. It's just one day they have a flat one, and some other day they have them like this. They look a bit like raspberries. Now, not all dermal nevi are papillomatous. You can have smooth ones as well. And the one on the face is often skin coloured. So that also starts as a flat brown patch in a child, but in adult life becomes a skin coloured papule. And they're often around the eyebrows or around the nose or on the jawline, and very, very common. In dark-skinned people, they're skin-coloured, so they're also dark. So they can be absolutely black, in fact. And in fair-skinned people, they tend to be skin-coloured. But the patient may come to you saying, my mole is losing colour. And that's a normal, expected evolution of this type of nevus, the Misha nevus. And they can have hair in. So often people will come to you and say, I want to, I've been pulling, well, they won't always confess to pulling out the hair, but they will come to you with a cyst underneath the mole because they pulled out the hair and irritated what's going on underneath. Or they will say, the laser lady wouldn't remove the hair. She said I had to see the doctor first. So it's perfectly safe to have laser hair removal if they want it. It's certainly better than pulling it out with the cyst underneath.
Can we be totally relaxed if we see a nevus with hair? Are there any exceptions?
Well, melanomas with hair. I wouldn't be relaxed if you saw a melanoma with hair.
So melanomas still can have hair?
Of course. Of course. Remember, the hair grows deep and the melanoma often starts at the surface of the skin, so it's got to get pretty deep before it will destroy hair. Basal cell carcinomas usually lose their hairs very early on because they're very destructive tumours, but they don't always, and I have got some pictures of BCCs with hairs. So no, destroy that myth. Now, childhood onset nevi can disappear, and when they do, they usually do it by the halo phenomenon, which is a sort of T-cell and antibody-mediated process. So you have antibodies circulating, they're called anti-melanoma antibodies actually, but they destroy the nevus, and a cellular reaction does it. So you start off with a brown mole that's just perfectly happily sitting there, and then you develop a white halo around it. That's a stage 1 halo nevus. Then the mole in the middle begins to fade and may shrink. That's a stage 2 halo nevus. Then all you're left with is the white mark. That's a stage 3 halo nevus. And eventually the pigment returns, which is stage 4. Now that process takes on average 8 to 10 years. It's most common in adolescents, but it can occur in children and adults. If it occurs in somebody over the age of 40, think melanoma. But it's metastatic melanoma that causes halo nevi, not primary melanoma. Okay, which of these two is our dermal nevus? So they occur in children, but they become lumpy in adults. Okay. Some thought required here, and some thinking is too difficult. Colin, where are you, Colin? Colin, which have you chosen and why?
I'm going to choose B. Put the wrong colour up.
Tell us why.
A used to be one of those ones that grows through fungating one on the
Not fungating, that's
fungating, but right. The B is flatter, it's circular, it's uniform colour.
Okay. If I got rid of the word dermal and said which is nevis, which one would you choose?
Probably the same one.
Okay. Well, they're both nevi and they're both dermal nevi. So there's several types of dermal nevi. They occur in children, they're developmental. And there's the smooth top kind and there's the papillomatous type. These are quite firm and these tend to be softer and wobbly, but they're both dermal nevi. On dermoscopy, the papillomatous one is made up of the cobblestone pattern. So the cobblestone pattern is basically clods joined together, maybe overlapping a little bit. So they're very distinct collections of nevis cells that make up cobblestone. Now, with the other kind, so this is the papillomatous soft kind, the other kind we see just structureless, really, maybe skin-coloured white to black. And often there's just little flecks of colour. Not enough really to say it's a dot or a clod or a line or anything. So they're structureless, but not necessarily homogeneous. So that type of dermal nevis is also called a nuna nevis. That kind of one is called a meta nevis, cobblestone versus structures. So both dermal nevi, both harmless. Both arise in childhood, but develop into more bumpy lesions in adult life. Okay, which of these two is a combined nevis? Okay, this is very uniform. Let's see what Sue thinks. Where's Sue?
I thought B because the dot in the middle looks a bit like the pictures of the blue nevis.
That's right, absolutely. And it has another brown one on it. What do you think's going on here? Because that's got two components as well. Not sure. Is there any test you'd like to do to help you? Say it.
Yes, like a dermatoscope.
Okay, well let's get the tomatoscopic view. Now, here we've got our blue nevis within another kind of nevis, but I'd like you to describe what we're seeing with this one. It tells you at the top and the bottom, so all you have to do is read it out. Sue?
So it's got two areas which both hands within, but they're distinct.
Yes.
Hands.
And the one at the bottom has
globular. Well, now I can't tell the difference between that and clods, I've got to say.
oh, that's but you don't. They're the same thing.
Okay, right.
Okay, so they're different terminology. So the original dermoscopic terminology was to call these globules, and then they defined it and said, oh, well, we're going to define globules as round or oval, brown or black structures. But then what do you do if it's yellow? What do you call it then? And what do you do if it's rhomboid instead of round? What do you call it then? So Harold Kittler said, let's call them all clods, and they can be any colour and any shape. So both terms are in use. That's a globular nevis, made up of clod pattern. And this one, you won't be able to see from up there, but it's made up of lines. You probably see it as structureless from the back there.
Excuse me, with that combined nevis, you're saying that they're not very common at all. Do you think, like, when you're looking at that, I'm thinking, I'm always going to be cutting that out. But do you think that you're going to give me enough confidence that I'll see something with that much colour variation and I'll go, oh, that's a combined nevis, I'll just leave that alone?
You can tell me at the end of the day. I mean, obviously we don't want to remove benign lesions, but you've got to make a living somehow. That's That's a dig. The taxpayer pays for you removing things that don't need to come out.
Well, it doesn't issue the histology. And you have to.
Oh, but don't think that the histologists are always right, because they're not.
I would have taken that one out too. I knew it was a nevis because it said up there.
Fine, not a problem. I'm very relieved to be able to say you're only going to be taking a few of those off because they're not very common. And something that you're not familiar with, you know, you're either going to refer to someone else or remove. Okay, but these are every day, all day, the 300,000 to 1 million moles that don't need to be excised. So this is an exercise, a completely random choice, but could you make your mind up which of these two is acquired? That is to say, was not present at the age of 5 years of age. We've got some really, really confident people. Is Danielle one of those confident people?
Not really. my obvious cue is, can I see what they look like under the Dermoscopy, please?
Yes, absolutely. But you chose the one on the right.
I did.
And let's give us a clue.
Only because it's a little bit more irregular than the other. That was really the only.
I was hoping you were going to say it's a little flatter than the other.
Well, it is flatter.
Yes, because what I've been trying to impart is that early onset nevi come from the dermis, and so they're palpable. And later onset ones are flat. Ish. Usually. Okay, so Danielle, what are we seeing here?
You're seeing a globular pattern of pods, yes, which is relatively regular in terms of its border, as opposed to the reticular pattern, which is irregular, which is what I was seeing, but obviously isn't concerning now that we've seen it.
Exactly. So just to repeat what Danielle said so nicely, the globular pattern is basically collections of nevis cells in nests, and they're in the dermis, and they're from the developmental stage. If you damage your skin by throwing it out in the sun, and you develop a collection of nevis cells on the surface of the skin, they're going to be within the epidermis, and that results in lines. So it's not, you can have lines in a congenital nevis, or tardive nevis, and you can have dermal components in an acquired nevis, but they're usually only in the middle. So sometimes this is called a Clark nevis, and they're the thing that you're looking at when people come and say, can I have a skin check, and you look at the back and you go, because there are hundreds of them. And what then happens, of course, is you get nervous and you look at the person's back and you see lots of these and you think, oh my God, what do I do? And you think, oh, I'll take the one that looks worst off. Anybody done that? I'll just take the bad one off, and if that's okay, then probably the other ones are okay as well. And then you get back a report that says dysplastic nevis. And then you think, now what do I do? Do I take all the other ones off or what? And the answer is dysplastic nevis should no longer be reported. The pathologists are going against a scheme in 1994 that said, do not report dysplastic nevi because the clinicians don't know what you mean. So now they will use the word atypical, and they'll talk about architecture and cytology. So the architecture is the most important thing really, because this has very uniform architecture. You can see that from the dermoscopy. It's the same all over.
Can you just show what you mean by the lines on that second one?
You need a new pair of glasses.
I don't know. I may do.
Yeah. The best place to look is on the edge, and you will see
They're
very fine intersecting lines. You can, come on, and here. Actually, that's too close. You need to be at about this level. About here. You can see lines. A mesh, a lattice. It'll get easier. It will get easier. But you're not seeing clots, are you?
No.
A line means it's elongated. They're all over the place. And here. Okay, lines.
So these are the lines.
No. You're looking at, those are skin lines. That's the skin line. Brown lines, yes, brown lines. It will get easier, I can promise. So what? Now, it's an exercise to say, hey guys, why are you struggling? And of course, I look at these all day, and sometimes, you know, you see an elephant, you know it's an elephant, but you've never told that an elephant has 4 legs, a tail, and a trunk. You might say this has 4 legs, a tail, and a trunk, and not call it an elephant. So, we have to do some histology. Okay, we have the epidermis. Does this look vaguely familiar to any of you? And this is the dermis. And the dermis has got things like blood vessels in it, and nerve fibers, things like that. But it also could have nevis cells. So if you have a dermal nevis, you get nevis cells forming little lumps like so. And we see that as a clod, and that as another clod. Okay? But if we have a very superficial collection of nevis cells, they're in the epidermis. Like that. And if you look, as we are, from up on high, and we look down there, we're going to see a lot of brown cells. But if we look here, we only see one. This is what we see as a line, and this is what we see as no line, or it might be no line here. And of course, this is biology, and it isn't a very clear-cut line like I've drawn. It is fuzzy. And this, anyway, is a dysplastic nevis, which, as I said, is a particularly tricky one. The bigger the mole, the more often that you can't really see the lines. They're very fuzzy. They join together. If you look under a histology, what happens then is you get broadening of the rete, and you end up with a broader line. And sometimes you lose the line altogether. And if you have more sun exposed, so here we've got the sun coming down, then you get more pigment production, and again you get blurring, because you then start getting pigment all the way through. So the lines are much clearer in people who haven't been out in the sun, and they're much clearer in smaller nevi on the whole. It's not a perfect rule. And we will see some with lovely lines that you can all see. Next time I'd better put that picture first. Okay. So a dysplastic nevis is a normal benign nevis. Okay, it just means that it's appeared later on. They tend to be on the upper trunk, and they're completely and utterly harmless. They are not melanomas. And we no longer call them dysplastic nevi.
That's later. It gets reported later before we can
the difficulty in we are faced with is we can all tell that this is a melanoma, okay? Easy peasy. We can all tell that this is completely harmless. The difficulty is that this is a spectrum, And where are you on the spectrum? If you're a patient, you're somewhere down here. If you're a medical student, you're there. If you're a beginner dermoscopist, you're there. If you're an expert dermoscopist, but we've still got some don't knows. Now, if you look at pathology, it's exactly the same. They have the benign nevis, they have the melanoma, and somewhere along here they have a I don't know. And they've chosen not to say I don't know, which is a pity really. I wish they would, because we can all live, I mean, medicine's all about I don't know, isn't it? We do it all day. We say, that's X, that's Y, and that's I don't know. We live with that. But the pathologists don't like that. They like cut and dried. So they make our life difficult, and they say, oh, well, it's atypical. And then you don't know what to do with the answer. And it's very naughty of them, and they ought to just say, I don't know. But currently, if they say it's mildly atypical, that's benign. And if they say it's severely atypical, that's malignant. And if they say moderately atypical, don't know. So if it's mildly atypical, you just tell the patient, that's off, don't forget, don't worry about it. If it's severely atypical, you say, the pathologists call this severely atypical. That means it's very hard to tell the difference from melanoma. So let's make sure we've fully removed this lesion with a margin, and I'd like you to come back in 3 months so we can just check things. And if it's moderately, it depends on the patient, what you tell them. So I just wish they'd say, I don't know.
If it was moderately, could you hit your bits by like doing a biopsy? Would that be worth having a different area?
Can I say again, if I haven't already said it the first time, that the management of a lesion suspicious of melanoma is excision with a 2 mm margin. And I'm not going to say anything else, or referral to someone else. So if you choose to refer to someone else, they're going to either say this is benign, or they're going to excise with a 2 mm margin. Now, there are reasons for doing incisional biopsies, partial biopsies, shave biopsies, punch biopsies, and so on. But that's the advanced class. And they're not very frequent reasons.
So if you do a 2 mm biopsy and it comes back as a melanoma, it has to go back for a wider excision?
So you've got a 2 mm margin. So then you go and read the standard. So the standard says you will excise a lesion suspicious of melanoma with a 2 mm margin. Now you have a histopathology report, and you go back and do a second procedure for melanoma, depending on the T stage. So T1A, T1B, T1, T2. Am I leaving you for dead here? Need a bit of help with the T stage? So tumours are staged, and the T stage is the tumour stage. So we have N for nodes. I don't deal with those. M for metastases. I don't deal with those. We deal with T for tumour. So T1 tumour, you can look it up, but the AJCC, that's the American something or other of cancer, they decided that T1 was a Breslow thickness of 1 millimeter, 1.00 millimeter or less. T1A is 1 millimeter or less, and no ulceration, and no mitoses. A T1B is 1 millimeter or less, but there's a mitotic figure, or there's ulceration, which upgrades it. T2 means it's more than 1 millimeter in thickness. And you should know about these because the standards say that primary care can look after lesions that are T1A or in situ. So it is usual, of course, to refer a patient with melanoma to secondary care, but it is not required for T1A or below, but it is required that they have a re-excision, and that's according to the standards. So the standards say that if it's in situ, that the margin of the second procedure is 5 to 10 millimeters from your surgical margin, not from the original count, from the surgical margin. The standard says that if it's a T1A, that it's a 10 millimeter re-excision from the surgical margin. So that's not 10, it's not 8 millimeters because you've already taken 2. It's 10 on top of the 2 you've done already. And that's the standard. And what will happen if you refer to secondary care in mesomed? Any further discussion about that?
Can I just ask one question? I understand about the 2 millimetre margin if you suspect melanoma. If your surgical skills due to where it is or the size of whatever are not up to excisable 2 millimetre margin, so you're referring to your secondary care and the patient can't afford a private option. Having spoken to my friend in dermatology registrar this week in a city just a bit north of Hamilton, the waiting list the waiting list was 8 weeks for melanoma or anything else in the particular place I was referring to. And they said I had a fast-growing SCC in a place I can't too big for me to do anything. And I was just wondering, is there ever an indication for us to biopsy that while waiting somebody who's going to do definitive excision?
You mean as a surgical biopsy?
No.
For your SCC, yes.
Oh, yes, but yes.
If you think it's a melanoma, no. So should we go back to the beginning slides when we had the HSC? So that's coming in June 2016,
yep.
And the ministry is requiring all district health boards to see patients that fulfill those criteria. That is to say, you have a photograph, and either the dermoscopy is typical of melanoma or you've got the other criteria. The patient is seen in 14 days or less.
Wow.
So that's their aim. We have a 15, that's a 15% compliance at Waikato Hospital with that requirement at the moment. But mostly the patients come into no harm at all. How long does it take to grow a melanoma?
Yeah.
The difficulty comes in nodular melanoma. We'll probably seeing them quicker doesn't save their lives anyway, because it's a very aggressive tumour and bad luck.
Okay, that's all. Thank you.
So what we're really trying to do is to see people urgently to relieve everybody's anxiety. So my data on current triage, so we get referred patients with melanomas and non-melanomas, and I look to see how many are referred under HSCAM, the high suspicion of cancer. And I only had one invasive melanoma in that group, where all the other invasive melanomas were referred under routine or subacute. And when I looked at all the ones which were high suspicion of cancer, most of them were seborrheic keratoses. So we've got a way to go. We've got a way to go. And this is why you're here, to help, so that you'll be able, in June 2016, to fill those forms out better and provide the triage doctor. Registrars don't do the triage for good reasons, but triage is done by a variety of people in New Zealand. Sometimes it's otolaryngologists, sometimes it's surgeons, sometimes it's nurses, sometimes it's dermatologists. But the training is variable, and we know that in general practice there are a lot more skills than there are in the hospital for some of these things. But we're moving forward, and it is going to get more uniform, and hopefully the patients will not suffer too much in the meantime.